with an extremely elevated beta HCG. Okay, so non-pregnant woman with extremely elevated beta HCG, extremely elevated beta HCG hormone. Okay, and this mass appears as a complex solid mass. Complex solid mass and affecting one or both ovaries. May be one or both ovaries. Okay, this choriocarcinoma, you can feel like it could be an non-gestational trophoblastic disease because the patient is not pregnant, but there is an aberrant placenta found in the ovary and it's a malignant form, and this chorion produce beta HCG and there is an extreme elevation of the beta HCG. How come she is not pregnant but pregnancy test is positive? Same thing, if it is the man testicular choriocarcinoma, then his pregnancy test will be positive. Okay, and this is important because choriocarcinoma can be very aggravated. If it is a gestational trophoblastic disease, that molar pregnancy, and it causes the choriocarcinoma, that is very aggressive. Okay, that could be very aggressive. Okay, so this is choriocarcinoma, and the last one I want to say that secondary ovarian malignancies. Oh, okay, so this choriocarcinoma in the ovary, the chorion is usually brighter. Okay, okay, and it might have some necrosis in the center, but this is brighter tissue. This is ovary. This is ovarian follicle. Okay, so the last thing is secondary ovarian malignancies. So far we get the germ cells tumor. There are 3 germ cells tumor we found. That is solid teratoma in malignancy, solid teratoma, dysgerminoma, and choriocarcinoma. They are the germ cells tumor, even though they are rare. Okay, so primary malignancy is done. Now secondary. Secondary ovarian malignancy. Secondary ovarian malignancies, we are going to discuss it, but the metastatic form of this malignancy that usually comes from the other organ. That means the primary cancer is in the different organ, like a intestine, colon cancer, that can migrate or metastasize to the ovary, but it's rare. The cancer from the uterus can go to the ovary. Okay, so this type of cancer, and it may come from the breast too and other pelvic organs. Okay, so now metastasis from other pelvic organs. Example, tumor of the GI tract, and breast. The sign and symptoms are the same as the primary cancer. Sign symptoms are same as the primary cancer, primary ovarian cancer. And what are the sign symptoms? The initially asymptomatic, but you have to understand, as it is coming from the primary, it maybe tumor is in the GI tract or the breast, so they know that they have the cancer in the breast, in the GI tract, and that's why this type of patient needs to go evaluate every 6 months that whether the primary cancer is spread to the other organs or not. Okay, so now sign symptoms will match with the primary one. Okay, appear as a complex mass. Complex masses and are frequently associated with ascites. Complex masses frequently associated with ascites and there is a name Krukenbeck tumor. So this is the name given to an ovarian metastasis from the GI tract. Okay, that means when the primary cancer is in the GI tract and it is metastasis to the ovary, is known as Krukenbeck tumor. Krukenbeck is a name of a person, maybe the gynecologist. Okay, renowned gynecologist. Okay, so this is secondary ovarian malignancies. Always keep that in mind. Anytime if there is a cancer to any organ, always look for the secondary metastasis. For pelvic organ cancer, for abdominal organ cancer, you must look for the ascites, fluid, in the peritoneal cavities. And in the peritoneal cavities, look for the fluid in the Morrison's pouch, paracolic gutter, and the subphrenic right and left, or suprahepatic or suprasplenic. And for the pelvic, you need to look for the free fluid, especially in the posterior cul-de-sac. If the ovarian cancer is recognizable, is bigger, definitely you will see the free fluid, and the most of this free fluid are transjudative and bloody color, blood color. Okay? You might see some bleeding inside. You might see some blood clot floating inside the fluid collections. The sonographic characteristics are very important, because sonographically you can figure it out, any cancer in the ovary, what could be the type. Is it benign or malignant? There are some characteristics. You need to figure it out. And they will do the other modalities. They will take the patient's history and everything, and they will figure it out. Also, what are the stages of the cancer, and they will do the biopsy, and the report will come, and they will manage the case according to the protocol. Okay? Make sure. If you see any complex mass in the ovary, any complex mass in the ovary, it is suspicious, even though it could be 1 centimeter. Why? Because that could be the beginning of a complex cystic mass, maybe serous cyst adenocarcinoma, mucinous cyst adenocarcinoma, or could be other cancerous complex looking inside. But a complex cyst in the ovary is always suspicious. But you can say it could be an abscess. Yes, it could be an abscess. But along with the abscess, there would be some associated symptoms. High fever, pain, WBC count is high. Too much pain. If it is other complex cyst due to some bleeding inside the follicle, it looks like a complex. Yes. It could be a teratoma. It could be a dermoid. Yes, it could be complex. But if a complex cyst is there, a small, it needs to be evaluated. Maybe every 3 months, it needs to be updated, evaluated. Okay, follow up. And based on the doctor's experience, based on the age of the patient, based on the parity of the patient, if it is suspicious and they don't need any, or she doesn't need any ovary, they should take the ovary out, send it to the lab, and let the report comes. It's better to have no ovary when it is suspicious of the as a malignancy and your family size is fulfilled. Just like the breast cancer. When the BRCA1 and 2 are positive, mutations are positive, so that means anytime patient may show the breast carcinoma. And you know the BRCA2 probably, yes, if the mutation is there, and that is also responsible for ovarian carcinoma. Okay, so breast carcinoma, ovarian carcinoma may run in the same time. So we need to be very careful, and we need to check all the necessity fulfillment, and patient will be managed according to the protocol by the gyneco-obstetrician or the surgeon. And that's all for the ovarian pathology. So today I'm going to conclude with this, and next time I'm hoping that I will discuss with pelvic congestion, that is mostly common the vascular cause, pelvic congestion syndrome, and I hope I will find time to talk about the infertility and its sono evaluation. Okay, thank you so much for your paying attention, and I hope you are enjoying the videos. Okay, thank you very much. Bye.